It's always unique in thinking about how the FDA looks at data, and I think the importance here is that there is a group of patients, however we identify them, and I think the key way of identifying them is to try to understand their bleeding risk and certainly their VTE risk. There's a group of patients that seem to get a benefit, and in the light of a heparin shortage, where we're looking for a therapy in these patients that you're trying to avoid heparin, I think there's an opportunity potentially to be thinking about the therapy there. And one might ask, and I guess I would ask, is if I was going to use it, what are some of the ways in which I would use it? How do I transition somebody who's on an injectable, whether it's heparin sub-Q or low molecular weight heparin? How would you say I should start with either rivaroxaban or betrixaban? How would I start that agent in somebody who's on an injectable from IV or sub-Q?
I think for most of those agents, we typically would use them once a day. My guess is it probably would be in the evening. That way, if you do your procedures, most people decide those things in the morning. And if you look in terms of the potentially an evening dose, it's just basically stopping the subcutaneous heparin and starting the next day with your oral agent. And again, if you're trying to limit it to those types of patients that are high risk for bleeding, for some of the trials, and they excluded patients with active cancer, patients that had previous active bleeds in the last 3 months, patients that have active gastrointestinal ulcers, patients on dual antiplatelet therapy potentially, and patients with pulmonary cavitation. So if you look at that percentage of patients, hospitalized patients, it wasn't that much in terms of looking at those specific criteria compared to the general patients, medical patients at risk that are hospitalized currently in the United States.
Yeah, I think that's right. And I think you're right that we would probably transition to once a day dosing, and we would probably start that patient whenever you either stop that agent or you could start it a little before you stop the IV, and just to make sure the transition worked. And so a lot of people would do that. What about other parental agents with this shortage? So argatroban, bivalirudin, fondaparinux. What are your thoughts about them?
So argatroban and bivalirudin have typically been restricted either for bivalirudin to the cath lab, argatroban to heparin-induced thrombocytopenia patients only. Fondaparinux, now its primary use is actually in venous thromboembolism prophylaxis in patients with a history of heparin-induced thrombocytopenia. All of those products are more expensive than rivaroxaban or betrixaban, so probably will unlikely be used for venous thromboembolism prophylaxis.
And do you think the lack of now that we have an antidote for, say, some of the 10A inhibitors, do you think the lack of an antidote for one of those parental agents affects you? Obviously, you mentioned costs. Any other things there? Does the antidote affect you?
Oh, sure. There's no antidote currently for either argatroban or bivalirudin. Granted, both have a shorter half-life,
yeah.
You know, so in terms of bivalirudin, even almost shorter than heparin. So that's an advantage for those. But certainly fondaparinux also has a very long half-life.
And one of the other ways we might be able to affect our utilization of things, we've now gotten from the world of writing on a piece of paper an order to actually electronically and then electronically managing our pharmacy inventory to thinking about other ways. Are there other things we should be thinking about that we could put in place as we get more digital about potential shortages?
Sure. I think the electronic alerts in health medical records can do a tremendous service to help make practitioners aware, especially if you're going to shift practice. So if you want practitioners to use certain drugs for venous thromboembolism, you'll get a certain list of medications that you can use. But some of the issues related to that are if you're going to move the practice to something people aren't familiar with. So one of the big concerns about the heparin shortage currently is that the drugs that are purchased usually are bought the same units per volume. So the bags are all the same concentrations, the vials and the injections are all the same concentrations. But if those concentrations aren't available, you're changing. And if you don't tell the nurse, the doses may change and the nurse is giving an injection, they're not aware of that the dose may change. Or the pumps, you know, while they're set or they're smart pumps, there's a higher likelihood for medication errors to occur once you switch products. So the other good part about the alert is that you can make individuals aware and say switch use to bivalirudin in the cath lab as an example. Or you could put something about using rivaroxaban as your choice where it wasn't a choice before. But there's a lot that goes into that when you have to communicate that to the providers so that medication errors don't happen.